Are we able to do that? Oh, we've got it in, we're being recorded. Is that okay, or shall we just continue time-wise? What would you prefer?
I think we can continue.
We'll just continue.
Everyone has joined, yeah.
Yeah, okay, right here. So I am absolutely delighted to be here. It's really, really lovely. And I first came across the Banyan by chance when I was on an academic tour of India in 2013. And through a set of circumstances, I ended up chatting to some people at a wonderful production of dance at the embassy. And I spoke to this amazing lady who was working at the Banyan, and she offered me the opportunity to go and see it. And so although I'd been told by my dean I was to keep to the programme and not to disappear, I took 3 colleagues, and we were very kindly escorted to the Banyan in Chennai, and I was just overwhelmed by what I saw. It was really, really fantastic. So when I ended up talking after Ramesh, Dr. Ramesh, a few
I'm sorry, you're on mute, Sue. I think just now it's fine.
That's fine. That's fine. I think you muted everyone. The joys of technology. So it's a delight to be here and to be sharing something of what we're doing in the UK. So, oops, I just need to, there we go. What are we going to be covering? Well, we're going to be looking at what understanding what social prescribing is and how it can contribute to health and well-being. We're going to look at the introduction of social prescription into primary care in the UK. So primary care is might be called community care. It's our first port of call when somebody's looking for a health service in the UK other than accident emergency. I'm going to share with you an example of a social prescribing practice that I was involved in setting up. And then we're going to look at a bit of the underpinning theory. We'll have a look at the evidence base and outcomes, try how the issues in measuring outcomes. And then we're going to follow that with just a few reflections and then this really important discussion. So I hope that's okay with everybody. To support the webinar, I put together a document of useful resources, which I hope you'll find helpful. So there's a number of links, and Aishwarya is going to send it out to you with your feedback form. And this just includes some of the UK guidance on social prescribing, because we've rolled it out nationally. There's some really good materials there and a really useful set of website links. I've got a few links about the development of a professional body of social prescribing link workers in the UK. There are some websites about some of the organisations that I mentioned in the presentation. There's some interesting bits about outcome measures in this document and some links to case studies and YouTube links, loads of really fabulous stories. And there's quite a range, so do follow through the links and see what's there, and some references. I haven't included any case studies in my presentation because it seemed to me that actually we hadn't really got time. So I really do recommend that if you want to sort of see how it's working here, follow through some of those links, and they're really, really good. So understanding social prescribing and how it can contribute to health and well-being. So defining social prescribing, Aisha's already very helpfully started off with a useful, very helpful description. And I was really pleased to see that coming through with the promotion of this webinar. So I often use a definition that came from a project in Rotherham in the northwest of UK. And so I've sort of taken the key components. And I would say that it's a process that leads to accessing a range of non-clinical interventions and activities. It's typically provided by, as in the interventions and activities, are typically provided by the community or the voluntary sector. And we'll talk about that a little bit more as we go through. These activities can impact positively on a person's individual well-being and their resilience. And here it's very much about developing resilience and working what we call upstream, so health promotion. It's a sustainable mechanism for people to get well and stay well. So good social prescribing will really develop those links so that people are not so dependent on statutory services. So it's sustainable within the community. It's about putting people into the driving seat so that they're in charge of what their health and their well-being, and they're not what we would call under the doctor in the same way. And it provides building blocks for personal learning and change. So it's quite an exciting movement. And in many ways, I feel you're probably doing this in lots of different ways in India already. And I'll tell you for why a little bit later. So here, what do social prescribing link workers do? Well, first and foremost, they provide time to talk and explore what matters to a person. And interestingly, in our GP setting, so we have general practitioners who are doctors in the community working in surgeries, and they typically will say, well, what's the matter? But here it changes the whole thing round, and rather than saying what's the matter, we start off, what's important to you, what matters to you. So it's a different way of approaching things. They're there to support people to take greater control of their own health and well-being. And having read about what BALM is about and what the Banyan is about, I know this is already very much part of your thinking. So I'm hoping to sort of share what we're doing. I guess there's going to be quite a lot of overlap already. It links people to a wide range of non-clinical activities, which are typically provided by our voluntary and community sector organisations. In the UK, we have always had a tradition about having a lot of voluntary work and about having charities that really support people in different ways. So we've always had that fringe of non-statutory provision. And this is about making use of that. It's very much about collaborating. And it's collaborating with the person you're talking to, and it's collaborating with local partners to support community groups, to make them more accessible so that people know about them, know how to access them, and how they can develop good relationships with them so it is sustainable. It's also about identifying gaps in the community assets. So we call these voluntary and community sector provisions assets, because they are. We're coming from a very strengths-based position. So it's about identifying where those gaps are and about initiating new ventures where those gaps are, so that we actually have a much more cohesive and more collaborative approach. So in the UK, we have a very broad remit about who might be able to access this now statutory social prescribing link worker service. And it is very broad. And by saying it's very broad, you'll see that it has a wide interpretation. It is, I must say, a non-urgent service. So it's for people in the NHS who are already have any of the following conditions, and these are the NHS criteria for referral at the moment. So anyone with one or more long-term conditions, whether that's a physical or a mental health long-term condition. Anybody who needs support with mental health. So mental health is coming through very loudly. People who are isolated and lonely, and during COVID, that's been a particularly obvious area, but this was all identified pre-COVID. People who have complex social needs which affect their well-being. People who are carers, and that's a really interesting group. So culturally, caring isn't as inclusive as it is in India. We have a different model of caring. Our family makeups are different, and our provision of caring is different. But it's identified that people who are carers have specific needs and often need some help in keeping integrated with their communities and with the organisations that support carers. And people who are frequently attending either primary or secondary healthcare. So primary healthcare is our first port of call. Secondary healthcare tends to be hospitals or where you need a second person to another set of expertise to help. I hope that sort of makes sense. Please do say if this isn't making sense, because I appreciate we're talking about two fairly different forms of healthcare and social care provision. Now, initially, the service was only for people over 18, but now it's grown quite a lot. And we're now beginning to look at actually who we might use for people who are under 18. I've shown a few pictures as I've gone along, and I meant to say that in the previous one, they showed a choir, and that choir is a community choir which was set up for people with breathing difficulties by some of our occupational therapy students, wonderfully as a result of an assignment. How good is that? It's really important to me to sort of think this has a very broad remit. It has a very broad interpretation of what social prescribing might mean. And in the early days, when we started playing around with this idea in the late 90s, early 200s, there were some services set up which were much more about signposting. And we had people called navigators who actually signposted people to services that might help them. But to my mind, for this to be really, really effective, it needs to really be embedding people into the community. And that requires a lot more time, and it requires a lot more, quite a variety of skill sets, quite an important mixed skill set, but also the skill set that can really begin to unpack what those issues are and to bridge people into the community assets. So it's quite interesting. I think we're still in the transition, and it'd be really interesting in the question time to see where you are on that. So we want to do a little bit of a poll, and I'm going to hand over to Ash to do this poll. So I'm going to stop my share, and we're over. Oh, that was very smooth. I'm going to go on mute while you apply it.
So this is going to be a quick poll. There'll be a QR code displayed on the screen. You can scan it using your phone, or the link will be displayed on the chat box. Mehak will display. You can go onto the link and answer anonymously, or you can use a name. Once we have all the results, it will be displayed on the screen. Okay. Just quickly, let me go ahead. So you have the QR code on the site. Just you can scan it and you can enter your. I hope it's visible to everyone.
No, it's not visible.
Oh, one second.
The slide is visible. The Slido
is not visible, is it? Okay, so maybe it's the full screen.
While Aisha's looking for this, I'll just explain a little bit about why we're doing this. We just really wanted to find out what people's experiences were. And does this resonate? So it's sort of quite helpful. It's just a little chat thing, really, to be able to see whether this resonates with your experience, whether this is similar. Do you use social prescribing in your area? Who does it? And most importantly, who pays for it? But if it's too difficult, Aish, don't worry, we can carry on. And we could always bring it in at the end.
Yeah, just 1 second. Yeah.
Yes, it's visible now.
Okay.
Sending the link.
Once again, you just have to scan and you'll get a pop-up. If you click on that pop-up, you'll be directed to a link where you can answer the question. We'll wait for a minute or two and then we can end the poll. So shall I end the poll?
Just wait for a few minutes.
Yeah.
If everyone has, whoever has answered the poll, can they raise their hands through the reaction? It will be helpful for us to know. And
That's fine. We have the count here. We have 34. Yeah.
Okay, can we go on to the next one, Nash?
Okay. Yeah, you can start voting. Right, shall we move on to the next one, Sue?
Can we do the next one, Nash?
Yeah.
Thank you.
I'll just unlock button. Yeah. I think we're done with the voting.
I think so. That is just fascinating. Thank you.
Yeah.
Right, okay. Right, thank you so much. That was incredibly interesting to see, and so fascinating to see it all change as we go up. Great to see that yes, there's a whole lot of stuff really helps inform what we're doing and what I understand of where it's coming from. And the the interesting thing is that for us, the state has started to pay for this. So let me just tell you a little bit about that. Which sort of, this is really why we went, why the state decided that it would start funding social prescribing, because it is really important who is funding it. And we've seen some really interesting things happen recently around that. So first of all, demographics was an obvious reason. People are wonderfully living longer, which is superb. But so we have an increasing aging population. People are living longer with life-limiting and longer conditions, which is also excellent, but therefore they're needing more care. And in sort of inevitably, demand outstrips supply of the UK statutory services. So we have free healthcare and social care, which is funded through our taxation. But demand is really outstripping what we can really provide, and has been for quite a while, for well over 20 years. And that's both in the services we can provide, but also in the personnel, in our health and social care staffing, for a range of complex reasons, which I can go into if you want me to, but won't now. There's been a crisis in primary care because there's been a shift from secondary care, which is expensive, into the community. And care in the community was brought in at the end of the last century, rolled out through this century. And when it first came out, I thought of it as neglect in the community because there wasn't the funding behind it. Funding has come, but it's putting a huge strain on the GP surgeries. And we don't have enough GPs. We've lost a lot of GPs recently. The GPs are general practitioners. These are the doctors that manage the primary care, along with a fabulous multidisciplinary team. There's a much more need to manage long-term conditions because, as I say, people are living longer and their expectations are much greater. There's a much greater expectation of what the population now expect. We live in a consumer society, and we have the internet. We can find out so much more. It's changed the whole way of delivering. The idea of the doctor knows best or the medics know best is no longer the case, you know, and that's been a hard transition. And we're really looking at how we personalize the statutory care that we provide. And that's a big cost. Funding is massive throughout, and it's never popular to increase taxation, and well, certainly this government isn't keen to do so. But actually we need more funding to provide the services that we expect. Services have improved to such an extent. It's a real big issue. There is a recognition that there is a much wider range of health determinants that can improve people's health and well-being. And that is definitely coming through. Evidence-based healthcare really proved that there is no magic bullet in lots of places, and we have very good evidence-based healthcare, still not altogether used, interestingly. It was recognised that we need a mixed economy of care, and David Cameron, some years ago, Conservative leader, introduced this idea of the big society. And actually, it is a good idea. I'm not strong in that area of politics, but, you know, actually, the idea of using society to care for each other is important. And my understanding from my visits to India and my knowledge of our wonderful Indian students is that you have a much better use of your big society. You know, that is much more culturally embedded within your society. And it's something which we've had to say, well, rather than expecting the state to pay everything, we need to use the voluntary and charitable community sector. And then on top of everything else, we had COVID, and COVID obviously, you know, was a game changer in lots of ways. And interestingly, in the UK, this all happened just before COVID. if we look at long-term conditions and the overlap between long-term conditions and mental health problems, this has been produced by the Centre for Mental Health, which is a really excellent resource. We use it a lot in the UK. It's 2015, so it's pre-COVID, and I reckon the balance of this will have changed by now. But in England, 30% of the population are living with some form of diagnosed long-term condition. And of those, 20% of the population also are living with mental health problems. Sorry, not of those, 20% of the, separately, 20% of the population living with mental health problems. I would say it's much higher than that now, and I think it's more 1 in 4. And the overlap is very interesting. So 30% of people with a long-term condition also have a mental health problem, which amounts to 4.6 million people. And then equally, 46 of people with a mental health problem also have a physical long-term condition as well, which amounts to 4.6 million. And we've had a lot of work looking at why people, those long-term conditions aren't being treated adequately. So there was a big issue with long-term conditions that we wanted to try and begin to address. So it sort of makes sense that that was a key criteria for the service that we're providing. Now, if we were to say, what are the wider determinants of health? And we were to say, you've got this little person with something makes up 40% of your health, something makes up 10%, 30% and 20%. And if I told you those were the categories, what would you reckon made up 40%? And do feel free to just share a few ideas on chat as we go. I'm just going to bring up my chat. So what do you think makes up 40%? And what do you think makes up 20%? And it's quite surprising. I don't know.
We've received one response, socioeconomic factors.
Yep. Well done. 20%. Well done. You are absolutely right on socioeconomic factors. So tell me, what makes up 20%? Oh, that's more tricky.
Social determinants is also another answer for 40%.
Yeah, physical environment. Yeah.
20%, I suppose it's physical environment. Several answers for physical environment. One person says social connection for 20%.
Yeah. Well, I'm going to shock you. Thank you so much for that. That's really helpful. Okay, I'm going to shock you.
Healthcare is 20%.
Look at that. That is surprising, isn't it? So in actual fact, socioeconomic factors, you are dead right. They do take up 40%, and that includes our income, our job status, family support, etc. And what's really worrying is access to healthcare and the quality of the healthcare that is provided only accounts for 20% of what makes up our health. The physical environment accounts for 10%, and the health behaviours actually account for 30%. And that's really interesting. So what we did was we began to say, okay, if it's only accounted for 20%, that is shocking because we're putting in massive amount of money into it. What do we do about the socio-economic factors of our population? Quite interesting, isn't it? Quite shocking in a way. Right. So in the UK, we had a number of pilot or vanguard social prescribing projects. Now, I've been talking to my students about social prescribing for quite a long time, and certainly the end of the 90s we were talking about social prescribing. And because I was training occupational therapists, and occupational therapists in my mind, as well as social workers, would make very good social prescribers, and it should be part of an OT's practice. So there are a number of good pilot and vanguard projects which looked at it and then had research embedded in that so that we could see, so what's the effect? In 2019, so pre-COVID, the primary care networks, which is a grouping of all the GP surgeries across the country, had national funding for social prescribing link workers for each GP surgery. And that was huge and massive input. So I'll talk a little bit more about that in just a minute, so you get a feel for what that means. At the same time, there were electronic databases of our services and assets being developed. And that was also a national rollout. And this was really, really important in terms of enabling us to know what was out there and how we might use it. Because up to that point, we hadn't got these databases. So this is a directory of services listing everything that the state provides, but also what voluntary and the charity sector and the social enterprise sector, not-for-profit groups also provide. And this is very much a work in progress. We do have one, but it's not got everything on there yet, but it's on the way. And it includes faith groups, interest groups, private organizations, anybody can put stuff on there. But they also have a QA process too. Then in Northamptonshire, on top of that, we had a local initiative called Spring, and that's a joint venture between a charitable provider and local statutory providers. So it's it's funded in a very, very different way. So it has some charity funding going in there, some not-for-profit, as well as some match funding from the statutory sector. And I'm going to tell you a bit about that now, because in our area, I work for the General Practice Alliance in Northampton, and we set up 2 social prescribing services. So just to explain a little, here we've got the UK, and primary care is now delivered through general practitioner surgeries, as I explained, and they're now grouped together in these primary care networks. So just an example, Northamptonshire has a population of over 750,000 people, and it has 16 primary care networks. So in 2019, 16 social prescribing link workers were employed, 1 for each network. And within a year, more have been recruited. In my area, we increased that a lot. And in some, so within 2 years, that had doubled. The General Practice Alliance, which is a GP federation that serves the primary care networks and provides additional services, they set up, for 3 of the primary care networks, they set up 2 types of social prescribing service. One was for the 3 PCNs, and that currently employs 9 social prescribing link workers. So you can see that would have been 3 and it's tripled. And the other is Spring. So this is this organization, and we employ 6 social prescribing link workers, including a lead occupational therapist and an admin person. And we cover the whole of Northampton. So Spring covers the whole of the county, and GPA has responsibility for the town of Northampton. And it's a very exciting new service. And you can find out a bit more about the GPA and its services if you follow that website. And again, that will be on the resource sheet. So the difference between these 2 services is a little nuance, because they both seem to have similar sorts of criteria. But the PCN service will only see people for about 6 months, 6 to 18 weeks is the norm. Whereas the Spring service will see people for a much longer period, certainly for 6 months minimum, but sometimes up to 2 years. The PCN one is coming out of a patient or GP surgery, and the social prescribing one is community-based, and it's looking particularly at people living in a deprived socioeconomic area. The PCN one is NHS funded, whereas this one is joint funded, and it's very much outcome driven. And there's an absolute return on investment business model, and it's quite difficult to work for because they're constantly on those outcomes. But they do also provide additional funding to support activities, so they invest a lot. For the PCN one, you really want people who are motivated to make short-term changes. Whereas for the Spring service, you're looking for a much longer behavioural change with engagement over 6 to 12 months. For the PCN service, you're looking for some support, but generally we're looking for people who have a greater sense of agency, and therefore you get a shorter term and quicker fix. Whereas here, you're working with people much more complex needs, looking to build up their resilience, integrate with their communities, and really start to self-manage their health and well-being. And we're expecting some bridging to those community assets. So they're 2 quite different services. And I thought it's quite interesting to compare and contrast the 2. So what do we do? Both services start in this way, and they start with this big question: what matters to you? In both services, we use the Wellbeing Star, Triangle's Wellbeing Star, which is an outcome measure, but also a guided conversation. And I'm going to talk about that in a bit more detail, a little bit further in, but it has 8 outcome areas and it uses a 5-point journey of change. We'll explore that. We go into some goal setting and the measure guides that. We then are involved in linking people to community assets using the directory and a lot of local knowledge. We're looking particularly at making those social network links. So where we can, linking people into social networks and involving them in the local community assets, but also identifying where there are gaps. Community walks are a big thing. You can tell this is British community walks because of all the bad weather gear people have got on. But it's being seen as a really good thing, and that's quite a typical thing that we're involved in. So that's just a sort of the process. The Rotherham project showed, well, where are those assets? What are we typically referring people to? And I've just put those up. And again, there's a link to the Rotherham project, because it just sort of shows what sort of people, what sort of activities we were typically referring people to. So condition management programs that support education, management of symptoms, healthy eating, exercise, all those behavioural change items. Activities which involve health and well-being through engagement. So this is really speaks to my OT heart. Lots of craft groups, music groups, gardening projects, cooking projects, men's sheds, which is like men's support groups, walking groups, exercise, yoga, IT, all sorts, wide range where people can get involved. Another area was actually looking at education and employment and wider community participation. And often going alongside that would be volunteering. So you might use volunteering as a stepping stone towards employment, using peer mentors, befrienders, and sort of all sorts of volunteering options like community car driving and the like. There was another sector of organisations and groups that we were referring people to, which relates to emotional and practical support. Lots of, and it depends who's doing the social prescribing as to how more prominent that is. And it's interesting, we had an OT and a social worker in our group, and the social worker was very much more on the welfare rights, the benefits of rights. She was absolutely superb on those. And the OT would be much more interested in the activities of health and well-being. And then specific support for carers. As I said, this particular group of people who we're looking for supporting. Because if the carer goes down, then actually that has much bigger implications on the person they're caring for. So it's a good investment to look after carers. And we have a fabulous organisation locally, the Wellingborough Carers, Northamptonshire Carer Support, which is based in Wellingborough Town in Northampton. And they provide an amazing support network. And so this was happening in Rotherham, but similar things in Northamptonshire. I hope that sort of gives a bit of an overview. So what is the premise? That's what we're doing. What's the premise? What's the underlying theory that we operate in? We certainly operate in a very much a social model of health, and that is so very different from a medical model of health. And obviously some of our social prescribing link workers are working in GP surgeries. And I'm sure that you are familiar with what a social model of health is about. It's very much looking at the environment in which people function, whether that's the physical environment, the socioeconomic environment, the social environment, and looking at the social needs far more than the traditional medical needs. It very much looks at the wider determinants of health and what makes a person healthy. It recognises the value of local community and being connected with assets in the community. And I've just included this amazing lady who I met on one of my visits. And this is her workshop and her shop. And I'm now told it's now operating from an amazing warehouse. But this was when I went to visit her. And this was a fabulous, but to me, this is absolutely wonderful social prescribing. She was working with the families of prisoners. And she was enabling them to connect with each other, to find that social connection, that bond, that support. And together they were making things which they then sold. And that supported them as their, sometimes, well, obviously one of their income gatherers was in prison. And they also offered a service of reconciliation as well. So it's about developing that community of when that person came out of prison too. Absolutely extraordinary. And I just felt that just absolutely is one of my best examples of working with the local community and seeing beyond the natural restrictions. It starts with the individual, not the system, or what the service has to offer. It's saying, well, what's important to you? And it asks, what's the matter? What matters to you? Not what's the matter to you. So it's very, very much coming from a strengths-based approach. Now, we'd said we'd have a short break. It might not be quite 7 minutes, but we felt we needed a little break so that you could just have a think. And I'd like to ask you 2 questions while you quickly go and get a drink and have a think. What are the philosophies and knowledge that underpin and influence your daily practice? So what makes you, what works for you? What are those theories? And what's the philosophy and knowledge that needs to underpin the practice of a social prescribing link worker? Because it's a big question at the moment. So if we were to take 5 minutes, would that be okay? And then we'll come back in 5 minutes' time. Is that all right? So just take a 5-minute break. I'm going on mute for a moment. I'll leave these questions up so that you can find them.
Thank you, Sue. You can enter your responses in the chat and they'll be read out.
Right, okay. I think we're on to our 5 minutes. We've completed 5 minutes.
I can basically narrate all the answers. So one of the participants has said that philosophy and knowledge that influence my daily practice is human connection, community dynamics. The answer to the second question that you've posed is building strong connection with local communities, regular interaction with them, identifying their needs and taking actions on those needs. The other answer that we got was overlapping for both the questions. Philosophies and knowledge, the answer is being kind, honest, fair and respectful, being a good listener, being non-judgmental, and being aware of mental health issues. Also, there's another additional aspect of basic knowledge of psychological first aid that's common to both the questions that you've posed. The other answer that we got is to practice SPLB. Dr. Tessie Matthews says that I feel you need to identify the potential capacities and limitations of your client. Then we've got an answer which says matching strengths of individuals with needs of the community and vice versa. So an alignment between the individual and the community. Then there is an answer which says currently a person needs to seek support when they're asked what matters to them. This is assuming that only some of us need support. Okay, this is a question, I suppose. How can social prescribing, yeah, I think this is a question. Self-reflection.
That's lovely. Thank you very much, Mark. That's very handy.
Patience and empathy is another answer.
Excellent. That's a superb collection. And I really just wanted to get us thinking, really. Whoopsie, there we go. Because if you've done a professional training, then you will have got a set of beliefs and values that your professional body and your training has developed. You'll have a body of knowledge which is drawn from theory, research and practice. You may have professional standards of practice and registration. Certainly in the UK, that's how our professions operate. And we also maintain those professional standards. So I couldn't say I was an occupational therapist unless I was registered with the Health and Care Professions Council, and I'd declared that I'd met the standards annually. But for social prescribing link workers, that body of knowledge isn't there yet, and your responses are fabulous. They are absolutely, yes, those are indeed the things that we need. But at the moment in the UK, when we're recruiting social prescribing link workers, there isn't a professional body backing. Well, there's the developing one, which is the National Association of Link Workers, which is really excellent, and there's an academic side to that. And again, those links are in the resource document. But there hasn't been a group together frame of reference or philosophy. There's some education, a lot about, and it was interesting that somebody said about knowing how to access those assets, and there has been some work on that. And there is some work on building up those good relationships and those communications, which is really important. But there are some other areas which aren't really being covered. So I've been thinking, when I've been working with my social prescribers, well, what would be the theoretical frame of reference for social prescribing? So if you know, this is only a few theories, there's loads and loads of theories that I could put in here, but these are some of the theories which I think are quite important. And if you're going towards developing, and obviously BALM is an academic institution, and if you were looking to develop social prescribing link workers, I think these are some of the theories that we might need. And I'm not saying that the ones outside the frame aren't important, because they are. And some of our social prescribing link workers have got those underpinning them, and some of them haven't, because we're not specifically necessarily recruiting professional people, as in people with a professional qualification. And they are professional, but not with a qualification. So I think some of the theories that go into making up what makes what should underpin social prescribing are definitely that sense of agency and efficacy. So all the theories underpinning those. Locus of control, absolutely crucial. What makes up vulnerability and what goes for resilience, developing resilience? How do we say mental health says self-sustaining? What do we put in place? All the recovery theories. Theories of change, motivational theory, learning theory, really important, those building blocks for change. The recovery model in the UK, I'm not sure if you're familiar with it. I can send links if you're not. Really interesting approach for mental health. Social capital, really, really important and not very often talked about. And we use the 10 keys for happier living, which is coming out of the positive psychology stable, and it's really looking at how to develop emotional resilience. So those are just some of the theories that we're using. And I felt it might just be worth sharing two significant theories with you. One of which is about social capital. I'm not sure how familiar you are with this term. For me, it's fairly recent, and I'm basing this on some work by Halpin and Chu, and then putting in a bit of evidence base from Tierney. So this is very simple, and normally we'd go into this in a lot more detail, and there would have been pre-work that students will have done, and we would use that. But just to give a taster, social capital identifies two different types of capital: the structural capital and the cognitive capital. And the structural capital looks at the infrastructure of social networks, the meeting places, the occupations that facilitate connection. And it's governed by shared values, norms, and rules that determine who might have access and who might be included. And it's often those things that we don't talk about, and it makes it very difficult for someone to enter into a new part of an infrastructure. So our networks might include kinship-based ones, work and study-based ones, interest-based ones, community-based ones. And these days they may meet in person or they may meet online. So it's another, completely, it's more complicated, isn't it? Now, on top of that, we have what goes on inside our head. So our cognitive capital. And there we've got the cognitive and emotional capability that frames our ability and confidence to join groups and form friendships. This includes the attitude, beliefs, and knowledge that lead to acceptance or rejection. And this can also relate to underpinning conditions that have some deep entrenched stigma attached to diagnosis. And that can really, really get in the way. Now, recently, there was an interesting study by Tierney, and Tierney et al. Found that social prescribing link workers represent a vehicle for accruing social capital. And they looked at this very issue. It's an interesting paper. And they propose that they are able to increase confidence, motivation, and connections, and that actually social prescribing link workers should be really important. They have that agency and are an important part of the process of enhancing social capital. Really interesting paper. So this is just a very quick visual way of looking at it, okay? So these are some of my networks. They're not all of them, but they're two in particular ones. So this is my book group, and this is my faith group. So there's other people inside and out, okay? It's just a really quick visual one. And we have places where we meet. So we meet in each other's houses in our book group, and we meet in church and in others' houses and other places for our faith group. We have a whole lot of activities attached to what we do, and we have shared values. And we have norms, and some of those are tacit and some of those are transparent. So some of those you know about and some of them you don't. And so, like, number one rule for the book group is you must have read the book, and you must only recommend a book that you have read. And you're in trouble if you don't. So do you know what I mean? So there's lots of rules. And if you start thinking about groups you belong to, some of those groups are very, very subtle. Now, that's our structural capital. Our cognitive capital all relates to, okay, all that stuff is out there, but how confident are we to make use of it? So we might have this little guy down here who's thinking, I'd like to join one of these groups, but I have a whole lot of worries and a whole lot of attitudes and beliefs about myself. I don't know whether I have the confidence to do so. So that person might need some friendly person, like that lovely person near the group, near the church, the faith group, who could be a bridging person, and they could enable somebody to join that group. But that's not all they need. They might need somebody within the group to actually help them bond. So what social capital is doing is it's giving you the language, the ideas, concepts, and then it begins to help you unpack and work out what you need to enable that deeper embedding social prescribing, not just the signposting. So I think that's a really useful theory base. The other really significant theory is a theory we use a lot, and this is 10 keys to happier living. I don't know if you're familiar with it, but it pulls together a whole load of psychology and anthropology and other areas of research, and it looks at what makes us happy. And it's not prescriptive. It's about saying these 10 things can contribute to our happiness. And most importantly, our emotional resilience. So it helps you to work upstream. And if things aren't good, then we might need to start looking at one of these or two of these to see what other things we might do. And in the GPA, we use 10 keys of happier living, and I'll show you in a moment or two how. But before we get onto that, we need to deal with the tougher bit of the evidence base. Now, as I've been preparing for this and before, I've read around a lot around this, and there are issues about our evidence base for social prescribing. And there are some real practical issues that create problems. And I don't think this is alone to prescribing. They certainly resonate with occupational therapy. I have a feeling they resonate with other areas like social work and other mental health practices. But there is a lack of clarity and consistency about what social prescribing is and what the interventions are. There are numerous variables, lots of interventions, loads of different stakeholders, contexts, and therefore lots of different meanings and experiences when we're trying to look at what outcomes there are. So how you identify and then measure the complexity of what somebody thinks matters to them is very difficult. There's not enough good qualitative research to unpack the complexity to then underpin the quantitative research. So we're still a long way back. There's far too many variables to consider any cause and effect, really, to be honest. It's such a complex thing. I appreciate you can do various forms of statistical analysis, but it's still very difficult. And our biggest problem is that there are no consistent outcome measures or research protocols that we're using at the moment. So there's very limited opportunity for randomized controlled trials, and many studies which are done are not then published in peer-reviewed journals, so they don't feature in systematic reviews. And there's really a lack of a research strategy. And so even though we've rolled out a complete program across the country at quite a cost, actually, we still don't have a research strategy. And it's a bit chicken and egg, which to do first. So when we look at a hierarchy of evidence, then we would quite naturally fall down the lower end for a good number of reasons. And I've faced this repeatedly as I did my master's as an occupational therapist, and in the education, this has always been a bit of a frustration. And I'm not sure the hierarchy is always the best way of looking at it. We've looked at alternatives, but for the purposes of this, I'm using this hierarchy. So I've looked at a few different bits of research evidence. There was a really, so before the 2019 rollout in the UK, there was a very important systematic review by Bickerdijker in 2016, where he searched 9 databases, but all from a very, very medical perspective. So he only looked at the medical databases. He didn't really look at, didn't include one database like ALMED, which has a lot of complementary professions in there, OTs in there. The research was between 2000 and 2016. It included 16 evaluations. And in those 16 evaluations, I've just popped them in the hierarchy so you can see where they turned up. So one was an RCT, there was 1 case control study, 4 case reports, and unsurprisingly, there were 10 in the bottom category. There was a very poor definition of social prescribing, and it didn't include any social outcomes. They were only looking at health and well-being outcomes. So it had a very medical perspective. All the studies showed some improvements in health and well-being, but it was very difficult to quantify the size of improvement. And they were very critical of the studies. They said there was no standard protocol. There was a lack of parity in data and detail, and there was all short-term data, which was sort of understandable, but it didn't really go beyond 6 months. So some really interesting criticisms. And this is one of the studies that is shown on the NHS website on social prescribing, which is interesting. Now, still before 2019, but in 2019, Pescini did a really interesting systematic review looking at the service user. So it had a different perspective. It looked at 11 electronic databases, including a wide range of grey literature and key websites. So it went much further afield, and it had a much broader perspective. It used Prisma as its protocol and a mixed methods appraisal tool. So it was much more able to look at a greater range of research. 16 studies were included. There was some overlap with the bigger DICOT study, which you'd expect, but it included 7 new studies. So we've still got only one RCT, 1 case control, but more were in the next category up. So there was 1 case report and a number of mixed methods with outcome measures included, and only 1 included in the bottom layer of expert opinion and descriptive studies. So they also observed poor quality of research. They assessed different types of quantitative service user outcomes, but they did include social ones. And there were more consistent qualitative outcomes, with 7 out of 8 showing service users experience improvements in health and well-being concepts and health-related behaviours, and a reduced social isolation. So it was improving, it was going in the right direction. So I'm moving a little faster because I want to get on to outcomes. The NHS, we look at particularly 3 areas of outcome. We're looking at the impact on the person, the impact on community groups, and the impact on the health and care system. Now, the National Academy for Social Prescribing has taken the research and is working with 8 other universities to really look at, well, what does the research say? And they're regularly updating, and it's really worth going to look at that. So they've looked at measuring outcomes for individuals receiving support through social prescribing, measuring the economic impact, funding models, and who is being referred. And they found that these are big sort of overarching reports. It's worth looking at the detail of them. The evidence suggests that social prescribing can reduce pressure on primary care and save costs. In terms of secondary care, it's more inconclusive, but some studies showed a reduction in the use of primary care, which would include accidents and emergency. And the evidence demonstrated a social return on investment, a favourable social return on investment, which then had some a range of outcomes, and there were some costs considered. So that was the impact on our health and care system. The one impact on the individual, it did overall show a decrease in loneliness. There were improvements in mental health and well-being across multiple measures. And there were improvements in social connections in overall well-being. But the caution is that you can't generalize these because of the issues about diversity of contexts. And there still needs to be more medium and long-term effects measured. So it's going in the right direction. It's a good place to keep an eye on. So Polly et al. Did a fascinating study looking at what does successful social prescribing look like, and they mapped the outcome measures, and this is really interesting. So they did a 2-stage study, and they found that there were 8 outcomes that related to the wider determinants of health and well-being. But sadly, these were the only places, they had outcome measures across all of these, but they weren't used consistently and they weren't used frequently. And this only applies for, and I just need to get my detail on this. So the ones I've put up here, these were the measures that were reported only by 22 reports, and that was only 8 of the 37 studies they looked at. So it really, really wasn't looking at the wider determinants of health. Bizarrely, looking at general health and well-being, there was far more. And in actual fact, this was much more regularly used. So 50% of the studies used the ones I put up. If you go back to the report, you'll find all the areas they were looking at. And they were looking at all of those areas, but not a lot. It was very scattered. And they were looking at some really unusual things, I felt, for a social prescriber, but it was still very medically orientated. So what did we decide to use in terms of outcomes? I presented to the clinical directors of the whole of Northamptonshire a sort of a critical appraisal of 4 different outcome measures, and we went for the triangles, wellbeing star, and the SWEM-WEBs, the short WEM-WEBs, which is looked at a much more overarching and they included the social determinants, which a lot of people wanted to use the patient activation measure. There's still a lot going for that, but it was very, very much on the health and well-being side and not looking at those wider determinants of health, which I feel really need to be in there. And I discarded this is the Office of National Statistics item 4 because it wasn't consistent enough for me. So the measures that we use in the GPA are the Triangles Wellbeing Outcome Star. We've integrated the conversation with the 10 keys of happier living, but not as an outcome. We've used this SWEM Webs, which has 7 questions looking at your mental state, and it's well tested, and we felt the shorter version was actually better than the longer version, which is 14 questions. These are the questions that are being asked. Now, interestingly, Spring wanted us to look at our usage of the healthcare directory, as in how many people were using it. I'm not convinced that's a terribly good measure because it's not really, it's not comprehensive enough yet. So looking at Triangles Wellbeing Outcome Star, there are 8 outcome areas, and these first 4 all relate to the wider determinants of health. The next 4 relate to much more health and well-being, so lifestyle, looking after yourself, managing symptoms, feeling positive. What is clever about this star is that it looks a bit like a starfish, but you can map out where you are on your journey of change from I'm not even thinking about this issue to this is as good as it can be. So it enables a person to determine what is as good as it can be in terms of their finances, where they live, and what is as good as it can be in terms of lifestyle and family of friends. It also enables people to decide which of the 8 they want to work on. You wouldn't work on all 8 at once. So it's good. And Triangles do quite a range of other stars, so it's worth looking at their website if you haven't already. I'm sure you may well have done. So then we integrate into the wellbeing star, the conversation 10 keys. So into lifestyle, we introduce conversations around exercise and self-care, around exercise and acceptance and self-compassion. So you can see how these all begin to just integrate completely into that conversation. So we're integrating the theory into the discussion that we have. And that's worked very well. And that's a sort of a unique scheme with the GPA. So my reflections. I'm very close to time for questions, but just a few thoughts. It was really wonderful to set up a new service, and starting with individuals has been brilliant, and to be truly person-centered, I think has been fantastic. And it's opened up some brilliant projects and bringing in some new people, because most of our social prescribing link workers aren't qualified. But there's some really big issues. We have long discussions. Should we have somebody who's a peer, or should we have somebody who has a professional background and the qualification? So social workers and OTs make brilliant SPLWs to my mind, and so would mental health nurses and a whole range of other professionals. I feel you need a body of knowledge, and you need something there, a code of conduct to be working to. These people are working very much in the community. And the big issue is data, because I've found it really difficult sometimes to get my lovely social prescribing link workers to record the data for the outcomes. And it's really hard. And it's not, I won't go into the details on that. I do think you need a theory base for practice. I think that it can be very broad, but you need some basics in there. At the moment, we don't have an award or the career path, but I think that could be a work in progress. For the PCN ones, working in the GP surgery has been a challenge, but it's been a brilliant opportunity as well, and they've been amazing, but it is hard work. And we had lots of issues about community working and people not being qualified to do that, whereas obviously, if you come with your qualification, that comes built in. And Tierney, this work about saying that, actually, the stakeholder buy-in is really, really important, and it needs to be from the whole group, not just the social prescribers, but the community that they're working within. So the GP surgery, really important. It makes a big difference. The title, Prescribing for Collaborative Working, doesn't really work, does it? But nobody's come up with a better one. And for here, working in the PCNs, the surgeries knew what, GP world knows about prescribing, so it worked there. People with complex issues. Oh, this is such a big issue. You know, people think it's common sense, but it isn't. And common sense in an evidence-based world, as I hope I've shown, is difficult. The reality of a catch-all, you know, it's such a broad group. We do need an agreed research strategy, and we need a skill set to effectively unpack and manage people with complex issues. And we've had a few issues with turnover, and I just feel it's really, really important. People should stay linked in. So how you pull people together is another issue. I'm sorry it's been a bit of a rush. But I hope that what I've said has given you at least a taster and set things going. So Aish, over to you, and Dr. Ramesh. Thank you.
Thank you so much, Sue. That was a wonderful session. We are actually nearing the second part of our webinar, which is the panel discussion. I now invite Mehak to introduce our panel members.
Hi, everyone. Thank you so much, Aishwarya. And I would just like to say that, Sue, that was a great session. You broke it down and simplified social prescribing so well. I'm not from the discipline and I had no problem following through. And it was a very engaging and insightful session. Definitely a very concise session. I would like to thank all the panel members for being with us here today. Special thank you to Dr. Samuel for being with us today despite contracting COVID. Yes, so these are the panel members that we have today. Yeah. Instructions for the participants. If you have any questions, please put them in the chat box and they'll be taken up for discussion during the panel discussion. Keep your mics on mute, please. That will be really helpful to maintain a healthier discussion and does not actually prevent any noises while people are discussing. Thank you so much. So Dr. Raja Samuel, I'd like to introduce him. Is principal of Madras School of Social Work. Dr. Raja Samuel is a social worker by education and alumni of Loyola College. He completed his post-graduation and PhD in NGO networking. He was also awarded Junior Research Fellowship by University Grants Commission. And he has over 2 decades of experience in teaching at PG, MPhil and PhD levels at Madras School of Social Work. He's also worked with an NGO for 4 years. So he's conducted about 15 research studies through social surveys, need assessments and evaluations. He has over 20 peer-reviewed publications and 30 peer presentations. Thank you so much, Dr. Raja Samuel. Dr. Sonia Pereira is also here with us. She's head Department of Psychiatric Social Work, LGBRIMH, Tezpur. She is also the Dean Faculty of Medicine and Life Sciences at Guwahati University. A postgraduate in social work, Sonia Pereira completed her MPhil from Neemhans and a PhD from Mizoram University. She's played a pivotal role in establishing the Department of Psychiatric Social Work and the Center for Rehabilitation Sciences at Tezpur. She started the very first clinical training course in psychiatric social work in Northeast India. She's also played an instrumental role in initiating reintegration and rehabilitation activities for marginalized communities within the region. She has championed public policy, public advocacy in the field of mental health, life skill initiatives, and social work, among many other things that she's done. I would like to introduce Dr. Lakshmi Sankaran, a counselor and a mental health practitioner for 20 years. Dr. Lakshmi Sankaran is the Deputy Director, Programs and Training at BALM. The TIS alumni, Dr. Sankaran completed her post-graduation in medical and psychiatric social work and has contributed immensely to the mental health and social work landscape through her research. She's taught at the Christ University for 4 years before she joined BALM. Dr. Sankaran has been involved as a consultant in an HIV/AIDS project in Karnataka, wherein she engaged in supervision, training, and assessment. Her academic interests include family therapy, addiction, gender-based violence, and substance abuse, among many other things. I would like to introduce now Dr. Ramesh. So a social worker by expertise, Dr. Ramesh is the Deputy Director, Programs and Training at Banyan Academy of Leadership and Mental Health. Dr. Ramesh did his post-graduation in social work, followed by a PhD in behavioral psychology. He brings forth over over 20 years of experience in mental health and social work, and has served on prominent committees for draft policies like the HIV/AIDS Bill, Tamil Nadu Youth Policy, Tamil Nadu Professional Social Work Council Bill. He is currently serving as member of the Board of Directors for Commonwealth Organization for Social Work. I would like to thank Dr. Ramesh for being with us here today, and he will be the moderator during the panel discussion. Thank you so much. Over to the panelists.
Thank you, Ms. Mehak, for introductions. So I would like to request our panel members to share their views after listening to Ms. Sue's presentation on how social prescribing is relevant in Indian context. So I'd like to request Dr. Raja Samvel first, and then followed by Dr. Sonia, and then Dr. Lakshmi Shankaran. Welcome, Dr. Raja Samvel.
Thanks, Ramesh. Thanks, Griffiths, for that very interesting presentation. We have been doing this, I think, in the Indian context. If I reflect on the content of what you shared, we have been doing this informally in several ways. That's the first image I get about social prescription. There's a lot of informal groups and services in the social sector. It could be a group of volunteers, it could be a local band of volunteers, it could be local networks, and these days, because of the technology, local WhatsApp groups. They've all come together, and they seem to be, in a very amorphous set of activities and services they are being provided. That's the similarity I see of what is happening. And interestingly, in the UK, you have evolved from a very formal general practitioner and direct practice setting to support that. Probably this has helped reduce the workload and so on and so forth, as you very clearly mentioned. But in the Indian context, this has been already there for quite some time, because there are a lot of areas where state services don't reach. And there are local communities that come together, band together, and that's where the concept of social capital, you beautifully brought in this concept, which is very, very relevant, the concept of social capital and the local social networks that have long supported the needs of the community in several ways. That's what I've seen that's happening. But there are also, when we try to systematize it, it's very amorphous and it's very unplanned, or sometimes spontaneously planned also. But when we try to systematize it and bring it into some kind of a framework, as you are doing in UK, what are the ethical implications? Probably we need to discuss on what could be the ethical implications. Would it be as rigorous as it is being followed in, let's say, in general practice, or in other forms of direct practice, or other forms of social work intervention or clinical intervention? So that's something that probably we need to cover. Interestingly, our government has rolled out a lot of helplines, and these helplines really connect the people in need to services or volunteers sometimes. And some of these helplines also use the services of volunteers. Even now, we have had requests from a group called Senior Citizens Bureau. They want to place one such volunteer in each district headquarters to receive the petitions from the public, and then connect them to services. Typically, it's a referral service. So I think whatever has been happening, that in a very amorphous way, you have beautifully given it a kind of nice shape to it, and a good identity is also shaping up. I'm glad about it. Ramesh?
Thank you, sir. Dr. Sonia?
Yeah. Good afternoon to everybody. Good afternoon. We are almost going into the evening. Happy to meet you all. I've heard about you guys. And of course, Sue Griffiths is somebody known in the field. Of course, we are really not too much into the theme called social prescribing in a way, but of course, it's a newer term that has come about since I think 2000, last 5 years, I think has been on. But I really think that the social prescribing role is something that the social worker performs. And it's no different from what a social worker, a trained social worker performs. And also the voluntary social worker, so to say, those who are not so trained, or rather the general social worker. But more than anything, I think what we understand from her presentation, from ma'am's presentation, Sue Griffith's presentation, is that it's something that needs to be primary systems. But I also understand that in India, the nature of healthcare is totally under the government. And of course, to a larger extent, yes, to some extent, I would say that if the NGO, the non-profit sector also takes care of a whole lot of activities related to health and to mental health to some extent. Yes, parts of India being a very large country, parts of India, the care that is given from the health sector is varied. There are remote places, there are hilly places, especially I have been in this region of Northeast India for the last 30 odd years. And healthcare is trickling down, slowly is trickling down, but I wouldn't say it's great. And the responsibility of healthcare is definitely with the government. And I think it is the mandate for social workers is not there down to the primary healthcare level. So that way, we don't really, it's not a statutory requirement that we as social workers, or as, as Sue Griffiths has been telling us that, as occupational therapists, the mandate is not there for us to work in primary health care as such. But one health personnel who's actually present in the healthcare system is the ASHA worker. The ASHA worker is the person who there's an ASHA, I don't know, maybe, of course, people in India would be knowing, but Sue Griffiths, I'm not very sure. I'm sure she would know if she studied the healthcare system in India, and she's been here before, that's what I hear. It would definitely, the ASHA worker is somebody who, there's a ASHA worker for every village. So I would say that the social prescribing has to start with her. And of course, there could be, tiers above the systems which could happen. It is there to a large extent, but I don't think the roles performed by an ASHA worker subscribes to the social prescribing role in the typical way that has been described. And especially the mental health component doesn't come into that system at all. And very often what has happened in India is that we don't have the luxury of having social prescribing in our system at all. And mental health is itself a luxury for India, for that matter. It is only some states that have gone ahead and they have their mental health policy in place, and the programs are in place, and various people, mental health professionals are in place to some extent. I will not say it's very much a statutory requirement, but it is there in place, but it's really not trickled down to primary health care level. And I feel the presentation that ma'am has told us about social prescribing is an area that we can definitely research into. And though she is telling, I think the role of social prescribing and the role of social workers in India, I think we are at par. What UK has, the status of social prescribing in UK and the role of social workers in India is almost at par. There's no question of our cities, of our role, of our presence or our interventions, except that some of us do it as part of, maybe we put up a project for the ICMR, or we put up a project for ICSSR, or, for that matter, we may take it up as part of our academic degrees. But, whether the system is working whether it's in place or not, we are really not too sure. But as our individual professional roles, we all do undertake the social prescribing role, and we bring it into our work arena. And it's part of our work, part of our social workers' work. And we are not too many in place, even if you count, but, we are into so many areas of work. So really, whether it is in health or social area, we really cannot very specifically talk about it. But it's there, I'm sure it's there, but it's not a researched area, it's not a projected area, it's not, there's been no RCT, there has been no, maybe there may be a few case studies that have come about, not more than that. And we're happy that this area is covered, but it's giving us food for thought for various areas to work in, or rather for research even, we could bring up these concepts and put it into perspective as part of our research work, which is very important, especially to, it's not only related to social work, it's related to all of us who are working in various social and health sector. It can be a large arena that is there before. It's like the menu that we have in a thali meal. It's a large arena, and so it's all of us. I think it's a wonderful thing that these notions have come through and these themes have been brought forward, and we could definitely put it into perspective. And this can be researched, but I think small areas can be researched and found out whether we can bring it into a perspective. And the link role that has been the link man or the link person, that has been described by Madam Griffith, is that it's more like the mover and shaker of a healthcare system or the social system, that is very much needed. And it is a need of the hour, no doubt, because with the COVID in place and with all the issues related to COVID in place, I think the mental health arena definitely has come up to forge and given a lot of impetus to the roles of mental health professionals, and it has made evident that the mental health care and care and the well-being part of it is very much in place. And one important thing that has happened also in India is with the new governments coming in and all that, these wellness centers have come up, are in the process of coming up at district levels. So every district is supposed to have a wellness center. So ideally all health personnel or so-called the persons involved in wellness should be actually playing the role of the social prescribing, which is very important. It needs to trickle down definitely. So that the few things that I caught on and I could, sort of share my views on it. If there's anything, we can always talk about it. Thank you.
Thank you, Dr. Sonia, for sharing our Indian experience. Over to Dr. Lakshmi.
Hi, Lakshmi here. I'm part of BALM, which is in Kovalam, Chennai. I think most of the points have been covered by Professor Samuel and Professor Sonia. Thank you so much. I think I loved the presentation by Sue, which was very validating. It was almost resonating with the kind of work we do, except that, we haven't used certain terminologies, but I could see a lot of intersections. So I'm just going to share a case that I was reflecting on from the Rural Mental Health Center where I was working. That's in Kovalam. The client was 40, previously on medication and counseled for depression. She brought her husband, 45 or so, from the local fishing community. The client came with difficulties of going to work and also had fits or seizures. He was diagnosed with alcohol use disorders, including fits, and had a secondary diagnosis of depression. So the couple continued to come for counseling to the health outpatient services. And some of the things that might fit into social prescribing was that the spouse or the carer, I'm using the word carer because I heard in Sue's presentation, the word carer and where social prescribing can be used for them, was referred to self-help groups, family groups, including special groups for women in the local areas. The client who was diagnosed and who was on medication, including counseling services, was engaged in activities such as gardening, prepared for vocational training to help him get back to livelihoods and support the family, was referred to the government services for disability allowance, was referred to AA groups for Alcohol Anonymous related issues, and to also for Al-Anon services. So these were some of the points that I felt sort of resonated with what Sue was saying. And I said, hey, if that isn't a social prescription, what is? So this is a case study from the Banyan, and thank you so much for the presentation. Thank you.
Thank you, Dr. Lakshmi. Many of us are reflecting what social workers are doing in India, and we thought, the same what you have listed, Ms. Sue, is what we are doing. But I'm sure the profession at the UK is also doing a lot of similar work like the social workers in India is doing. So how do they see social prescribing as a practice?
Well, it's a really interesting one, because I think it's the employer frequently hasn't valued social prescribing side of things. And so social workers are very often involved in a lot of issues around welfare and around children safeguarding and vulnerable groups, to the expense of the activities a social prescriber would do. And sadly, the same in some ways for occupational therapists, because Sonia, I resonated entirely with what you were saying, because I would say that's a natural job for an OT to be doing. That's what OTs should be part of their practice, but it depends who's paying and what they're paying for. And so we often find ourselves in roles which are not necessarily using our full skill set. And in fact, social prescribers, when they were rolled out for the primary care networks, they could be at what we would call band 5, and that's the starting point for a social worker in occupational therapy. But a lot of places like Northamptonshire only employ people at band 4. So therefore that's the one below. So it didn't require any professional qualification whatsoever. So actually what we have in place are people who may well be similar to us. I haven't come across ASHA workers actually, and I'm going to look at the link that's been very kindly sent by Mahak, which is very helpful. Sadly, they haven't used the skill set in that way. And it's partially because they haven't recognized how important those social determinants are in health. And we've gone down very much more of the medical model. So we haven't embraced and it's not been valued in the same way. So we have OTs working in the community in the same way as you have social workers. We have social workers working in the community. It's about 1 OT to 20 social workers in the community. So it's a disproportionate, and far more social workers than OTs. And they get very stuck with doing adaptations and equipment provision and not doing the real social prescription. And so it's very frustrating, and it's related to where the outcomes are and what return on investment people are expecting. So I, as a principal lecturer in occupational therapy, have been very focused on occupational science and how important it is and how OTs should be occupational therapists first and foremost and not get pigeonholed. But I know how easily they get pigeonholed. And from my social work colleagues and friends, I see the same thing happening, sadly. But you're right, you've absolutely got the skill set, but it's one that's in India that is the case, that you are using it in secondary care. But Dr. Sonia, did I get it right that you aren't positioned in primary care? Is that right? Sorry, you need to unmute.
Yes, social workers. No problem. Yes, Dr. Lakshmi, would you like to answer?
Was the question addressed to me?
Yeah, no, it's addressed to all of us. What is the practice in India?
Yes, so I was just reflecting on what Sue was saying. It may not necessarily be the role of the social worker. For example, in the Banyan context, it could be the counselor doing this service. It could be the NALM workers or the healthcare workers, community workers. So it's not about saying you will do this or you will do that. In the sense that it is recognized by the organization as a path to recovery, resilience, wellness, and recovery. Understanding that relapse and recovery are part of mental health components. So yes, one has to harness the help from the government, the state government, where there are schemes available, for example, disability allowance and so on, or even making referrals for certain conditions. which the NGO cannot support. You see, so I think I can say confidently that the Banyan is doing it. We recognize it. I think Ramesh is there to sort of, probably add to it. And some of my colleagues are also here. For example, we also did this, there was a small training done with a transgender group, which we're, engaged in. They rely a lot on social prescribing, a lot of it, because of the nature of work that they do. So I think it's very heartening to hear that, hey, we're doing this, except that, we're doing it. And I think everyone has to do it. It's a value that the organization understands. And I think that's very important, and a part of a policy is what I understand.
I think in secondary care,
please.
Sorry, in secondary care, we would be, so in mental health hospitals, then where we're using a recovery approach, exactly the same. It is very much part of the recovery approach. I'm sure there are examples of the Banyan. I'm thinking of a refuge, local refuge that we work in, and amazing refuge does all sorts of things. And certain organisations, yes, certainly have. And you're absolutely right. It is a whole person. It's a whole team approach. It's not just an individual. I think what's different for us is that it's been brought into GP surgeries, which is a very different world where it hasn't been before, and where they haven't had recently introduced OTs and physios, but that's a very recent, that's a 2020 introduction. So it's a change in the personnel, and it's a different way of going forward. And I think it would take a little bit longer in those areas for it to have that whole team approach. And that's important. Tierney's work certainly suggests that buy-in, that stakeholder buy-in is really important.
Thank you, Ms. Sue. Just want to ask Dr. Raja Samuel, being a head of the education institution, sir, how do you see, we can build academic component around this concept in detail, like what she listed down as theories behind and how to measure it, and the outcome studies that she said that there are very limited studies. So do you see a need, to build a academic component around this area in detail, so that the practitioners, will be able to do it, more in detail, not, superficially?
In fact, I had the same question running on my mind throughout the presentation. When what would qualify someone to become a what would qualify someone to become a social prescription linked worker? Is it a social work degree or occupational therapy degree, or now we have in India, we have a lot of positions in terms of social work, or even in the government particularly, where for one position a variety of degrees are eligible. For example, it could be criminology, it could be sociology, it could be social work, it could be anthropology. All these people are eligible to occupy that position. Are we heading somewhere towards that in terms of social prescription? As long, is there going to be, at least in the UK, is there some thought on what exactly are already courses being offered on social prescribing? All these are some of the questions that I had in mind, but I think it's an important, interesting area to work on, and see how we can consolidate that and introduce it. Maybe I'm just thinking aloud that it could be at the undergraduate level, somewhere of a social prescription, before somebody progresses on to a professional social work or a professional direct practice worker and so on. So I'm just reflecting whether we can have it at that undergraduate level as a social prescription linked worker. So these are some of the thoughts that have been running on my mind.
Thank you. That's a really good question. Several questions. So in answer to what's already available, at the moment there are some modules available, and they are particularly around how to make use of assets. So it's very much more skills based, and it's around knowing how to collaborate with local communities. We at the University of Northampton, where I worked, we put together some modules which would enable, which would actually look at some of the underpinning theory as well, because we have people who aren't necessarily coming, they aren't necessarily graduates, they're coming with a wide range of excellent life experience. And they, you know, I went into this with an open mind, and I have been really blown away by the skill set that people came with. But there's also quite a high turnover. And sometimes that's partially because people don't feel supported or don't feel that they can do what they really want to do, as in go beyond the signposting into the real embedding in the community. So at the University of Northampton, we put together some modules. We wrote some modules which could be used for anybody, and they were at level 4, so that's the first year of undergrad. Now, who would make good ones? Definitely OTs and social workers are absolutely in the right place, because they've already got that skill set. And I would think they would just need some work around visioning about what social prescribing might do as part of their normal practice. So it would be more about visioning about how you might use it and where you might use it. So if you're wanting to go into some new areas, then you might use, you know, particularly in the community where it's been said that there aren't currently social workers or OTs. So that might be a really good area about visioning and working together, a community of practice that would work there. In terms of what you might want in that, then certainly there's some theoretical background. We've looked at what theory might well be. And I would think it's really important if you're getting in people with a professional qualification. So, yes, sorry, if you're getting people in with a professional qualification, well, anybody really, you need to be looking at your research strategy too. So you need to be thinking, actually, you know, the criticisms were well made about the research, and it's really worth to start off thinking, so what protocol would we use? What research protocol? What outcome measures would we use? How could we be consistent? How could we be clear about what we mean by social prescribing? And then embed that in to whatever add-on you do. But I would thought that it could easily be a standalone development to a pre-grad level, but it could equally be an add-on into postgraduate, whether that's part of a master's or standalone. But it would be much more around visioning, looking at the research and looking at how you would take that further and collaborate with your communities. The fact that we've got this database is very handy. And that is very useful. And I don't know how you would start with something like that. That's been a very useful funding thing, but that is helpful. But perhaps your ASHA workers, because they're based in the community, as you so rightly said, they're probably your living directory and your bonder and your bridger, which is brilliant. Anyway, those are my thoughts off the top of my head. Does that answer your question?
Thank you, Ms. Sue. Just want to ask Dr. Sonia now, as a senior practitioner in this field, when pharmacotherapy and psychological therapies are a part of mandatory prescriptions for a client, so why we are still keeping this social prescribing as an optional? We want to listen to your thought.
Yeah, I think you ripped us on the right point. Every person who comes for treatment for mental health issues is not given the benefit of social interventions. That's a fact. It is always a referral system. The psychiatrist generally feels that if there is a predominant social problem, the predominant psychosocial problem, then only it gets referred to a psychiatric social worker or a social worker. In a mental health setup, it's generally a psychiatric social worker. Mm-hmm. So who's generally, of course, they are not many in number, but definitely they are there existing, and some of us are here too. But more than anything, it is definitely not embedded into the culture of having the norms of having social work interventions or psychosocial interventions as a mandatory requirement. And I think the time is very opportune that we as social workers, instead of having there is a thought what Ma'am Griffiths was trying to tell us, whether we build up curriculum, whether we bring up or build up. I think we are already there, and we just need to embed social prescription into our system, or rather use a terminology, use a nomenclature into this thing, and that gives us a very specific role. It happened. I mean, I've been in this area for the last 30 years in Northeast, and I really feel as we as social workers, our work is done by everybody else. But do we have anything for ourselves? That we are not sure. This is a very good opportunity to work and research and push forward the agenda of social prescription for the role as an added role of a social worker. And why it is that because most of the time in mental health is a medical model that is followed, though they all espouse, everybody in the system espouses a biopsychosocial model. But ultimately, when it comes to referring and making a compulsory requirement, is always the psychological and the medical intervention that are primary. The social interventions comes as a secondary requirement. But why, where, what? That's the system in place, which is the medical system in place, and that happens. But of course, many institutions do have, wherever there are psychiatric social work departments and where there are psychiatric social workers, it does happen. I'm not saying it's not happening, but yes, definitely. I think the parenting in the medical system is in question.
Thank you, Dr.
And
Sonia.
another issue that
Yes.
I think with the NEP coming in, the national education policy changing, and we have the requirement of moving over to a 4-year graduate program, which I feel is a BSW could become a 4-year. This is a very good opportunity to push forward the agenda of graduate programs for social work, and and every PhD ideally should have a social worker in the jobs, so that they take on the role of social prescribing, which is basically all that. Basically, what we do, the networker role that we play, is something that we all do it, and whether it's in mental health or in general social work that we do, we play the crux. The crux role that we have as a social work is one of help giving, and that turns around that we embed both the psychological and the social interventions within it, and we package it that way, that we embody all the so to say the holistic look, a holistic view, or the philosophy that is there in social prescribing is part of the role that we play as social workers.
Thank you, Dr. Sonia. Just want to move to Dr. Lakshmi because we have very short time to conclude also. Dr. Lakshmi, you were a student and you were a practitioner and you were also a teacher. From a student perspective, when somebody wants to enter into this kind of work as a social prescriber, I just want to create that nomenclature now. So what do you see as a challenge, for somebody to continue to work on this field or to start working on this?
I think, Ramesh, if I were to include this in the curriculum, I would say that instead of having another role, like somebody who's a social prescriber, I would just say that probably some elements of it through case studies can be brought into existing curriculum. For example, it could be part of casework or social group work, which already exists, but it can be sort of highlighted, or community mental health, some of the papers that we have taught. So, sort of bring it in and say that this is something that, we do, and probably invite a lot of resource persons in the Indian context. For example, ASHA workers, Nalam workers, for example, from the Banyan, include people from different, organizations who do this. So the point is not to say that there is a person who does this, but to say that this is important in mental health services and not create another specialist, which we really cannot afford to do. I don't think we need any more of that. But to recognize that this is an important entity. I think I heard somebody, I think it was Sue or someone said, directory of services. To make a good referral, what is it to do that? Not just refer blindly, but how do you connect both ends? You see, and these are important. I can see some NGOs who are in the organization. For example, there are some of them, maybe, they're already doing it. So it might be useful to hear some of their voices. So to bring it, I think it's there in the curriculum, but we haven't used these words, but we might use words like networking, directory of services, and so on. But maybe we can sort of refine it. Thank you.
Thank you, Dr. Lakshmi. Just few questions in the chat box. Just want to highlight. I think because of short of time, we will also ask Miss Sue to answer this later by email also. The context may differ in terms of determinants of well-being. Depends on the country and their the background, and then the task shifting. I think we discussed again who can do this kind of work, either it's a social worker or an occupational therapist or an alum worker, ASHA worker, or a different cadre on its own. Maybe last word from Ms. Sue, so that we can conclude this panel discussion.
Well, it's been a real joy to come and talk to you. And we are talking about quite different systems, but there's definitely overlap. And I definitely think there is a way forward. And if it was that we actually got some of our own natural professional bodies in our teaching more related to fulfilling, the skill sets that we've already got, that would be really brilliant. And certainly it's my hope that we would see occupational therapists and social workers more involved in that. And just thinking, Lakshmi, as you were talking about how you might embed that in the curriculum, it makes so much sense to use case studies, always excellent. And it would be really good to do some joint working with perhaps some other groups as well, other professional groups, to sort of see how they're coming together. I feel that the mix between social workers and OTs is particularly interesting because there is a lot of overlap, but there's also some slightly different expertise. And to pull those two together could be very, very exciting. And I hear what you're saying about not making another profession, and it is an all-team view. And I think that's a really good holistic view. How you share that with a wide group of providers is another issue. And the one good thing about, well, there's many good things about the system here, is that there is actually putting together of using one system. Part of our statutory system is using this, and that's been a good thing. And I'm just overwhelmed by what the Banyan and BALM do in terms of influencing policy. So I could easily see how you could, get that sorted your end in a very different way. And you'd have it with the advantage thinking, actually, we can learn from a few others. They made a few mistakes. Research outcomes did need to be more important, and start building on that so that what you're influencing would be absolutely right for your area and your culture, but also right from a practice point of view, and getting those things in place. It's been real joy to speak to you. Thank you so much for inviting me.
Thank you, Ms. Sue. Thank you all panel members. When we started, this discussion, we thought, we will understand more about how we can contribute to mental health. But your presentation has showed that we can move beyond mental health to physical health, even other social problems also. I think this particular technique will be of much help. So thank you all panel members for joining and sharing your insight. Over to Ms. Aishwarya.
Thank you so much, Ramesh sir. You had asked all the right points. I think all of us were thinking of that. We had all gained some clarity. And thank you, Sue. That was a wonderful and engaging session. It was quite insightful. And we hope to learn more from you, which was another point that I wanted to mention to everyone. We are planning to have a course on this so that we do get to learn a lot more about this and see how we can actively use this in our fields. I would like to thank all the panel members for that wonderful discussion. Thank you so much. I would like to thank Dr. Lakshmi Ravikant and Dr. Ramesh sir, Nagarajan sir and Vijay ma'am for their extensive support in organizing this program. And I thank all the participants today for attending. Thank you so much. And we will be sharing a feedback form. And you can tell us how we can improve our webinars. And we'll also be sharing a resource list, which will include academic papers and videos, all sorts of content that Sue has put up for all of us. And of course, do keep a lookout of the course, which will be put up on our website and on social media platforms. Thank you once again, and have a lovely evening.
Thank you, everyone. Take care.